First of all, thank you for inviting me to participate in this meeting. It's been really interesting, very interesting for me to hear from everyone. And also this has been, in some ways, the life I've been leading since our 2-decade cohort study began. So I'm really excited to think with you about why we should be concerned about aging and autism. So actually, every time I give a presentation about aging and autism, I start with this quote from Joe Piven, that autism is a lifelong disorder whose features change with development. And I think it's always important to think about autism from that perspective. But more specifically, I'm interested in, and I'm concerned about aging and autism to understand how to support healthy aging in autistic adults, to understand the natural history of autism across the lifespan, of course, to inform clinical care, services, and public policy, and most importantly, in some ways, to address questions about the future, because families and autistic adults and society in general always ask, well, what will happen as people grow into adulthood, midlife, and old age? So these are my goals for today. I'd like to use data from our 20-year plus longitudinal cohort study. We started with 406 individuals who were either adolescents and adults on the spectrum. And we've been studying them ever since. And part of our goal from the beginning was to understand questions about aging broadly defined, because aging doesn't start at a specific age, but it is a developmental process. So when our study began, the individuals on the spectrum were between the ages of 10 and 52. And their average age then was 22. And it's a community sample, not clinically based. To give you a sense in historical time about this cohort, the oldest people were born in 1946 and the youngest in our cohort in 1988. So that was the slice in time that this cohort, a big slice in time when these cohort members were born. Our research was funded primarily by the National Institute of Aging. Our first grant from NIA was in 2000, so we had begun a little bit before that. But they were interested in this both from the perspective of aging in two generations, the parent generation, as well as the generation of adolescents and adults with autism. Autism Speaks also provided funding. We're grateful for all of that. And so the way I'm going to approach this today is to focus on aging by looking forward and looking back. And by forward, I'm thinking about tracking change prospectively over the 2 decades of the study. And by looking back, there are some individuals in our cohort who have died during the course of the study period. And so we took the opportunity to look back at the predictors of mortality, all to understand what could in the future promote healthier aging. And then I'll end with a few comments about an agenda for future research. So this is just a graphic to show you the timeline of our study and how we rolled it out. And the participants in our study, for the average participant, there was a 22-year period between the time 1, when they first entered the study, and time 9, which we're finishing up now. And between time 1 and time 2, there was 18 months, and then time 2 to time 3 is 18 months, et cetera. The only differences in that time, in the timeline of our study, were between time 4 and 5 and between 8 and 9. And here it is 22 years later, and we have over 40% of the original participants still in the study. That's not adjusting for those who have passed away and for those participants whose parents have passed away and then they were not able to participate on their own. But that's just the raw numbers. But we think it's incredible. We're very grateful to these families and individuals on the spectrum who have stuck with us this long period of time. To give you a sense of what the cohort was like when they entered the study, about 3/4 were male and about 2/3 were living with their parents. Remember, the oldest person was 52 at the beginning of our study, so many were living elsewhere. About 3/4 were verbal, defined as using 3 or more word phrases on a regular basis. When they were diagnosed with autistic disorder. And of course, the diagnostic terminology and procedures have changed, but I don't think the individuals in our study would be unlikely to have been classified as having autism using today's diagnostic standards, although some have grown out of the diagnosis, as we have seen in other cohorts like Kathy's. 70% of our cohort had intellectual disability, but I just want to call out the fact that the highest IQ score among members in our cohort was 142. So there's a lot of variability there. Half had co-occurring mental health diagnoses, and we have health ratings throughout the study, and about a third were rated in the beginning of the study as being in excellent health, about half in good health, and the others in fair or poor health. So that's the snapshot. So there are so many ways that we can get a sense of what healthy aging is in individuals on the autism spectrum. And these are just four that I'm going to focus on: self-sufficiency and activities of daily living, social reciprocity, health, and longevity, just for the purpose of discussion today. But we could also think about these as risks to healthy aging: lack of self-sufficiency in ADL activities, impairments in social reciprocity, poor health, and mortality. So that's sort of the perspective that we're taking, is what are the predictors and what are the risks. So let's start with looking forward, and in a little while I'll move on to looking backward. Statistically, the way we analyzed our data to look forward is we fit these growth curve models, fitting individual trajectories for each participant. And because we didn't have the same number of observations for each individual, those with a greater number of data points are more heavily weighted. And in these analyses, we controlled for biological sex and socioeconomic status, and whether the person had intellectual disability or had average or above average IQs. And we fit these piecewise models to divide the age range by stages of life. So we have up to age 18 adolescence, 18 to 21 transition years, 22 to 34 early adulthood, and 35 and older as midlife and older age. And then we tested differences between those with and without ID at each stage of life. And for analysis of seizures, we had to do this differently. We used logistic regression. All these data that I'm going to show you for looking forward are at this point unpublished. We hope they'll be published soon, but I wanted to share this data, including the data we just are finishing collecting with you for this meeting. So this slide shows activities of daily living, self-sufficiency and activities of daily living. And I'm going to spend a minute on this slide because all the other ones are more or less organized the same way. The blue lines are for the individuals who do not have intellectual disability. The red lines are people with intellectual disability. And we show the two groups separately when they're significantly different. And the asterisks tell us when the slope within that stage of life is significant, and NS says it's not significant. And so what you could see with self-sufficiency and ADLs is that individuals without intellectual disability steeply gain ADL skills during their adolescence. And again, they gain during early adulthood, but there's a significant decline in ADL skills. Kathy alluded to this in her data too, during the midlife years and beyond, starting at age 35. And we see a similar pattern, although not as self-sufficient, for individuals with intellectual disabilities, gain during adolescence and decline after age 35. This shows impairments in social reciprocity measured at different points in adolescence and adulthood. And for those without intellectual disability, the blue line toward the bottom, we show they have less impairments than the red line who have intellectual disability. And they are gaining at a trend level more social reciprocity or less impairments in social reciprocity as they get older during adolescence and early adulthood. And then they're stable. It's really different for people with intellectual disability who show more or less stability during adolescence and the transition years, but they have more impairments during their early adulthood, and then they remain at that level as they age after age 35. These lines behind the images are individual trajectories. Again, they're plotted with the colors that match the legend. And it's really through these growth curves that you could pull out the dominant trend. This is prescription medications, all prescription medications. We've broken this down by psychotropic and non-psychotropic medications, and pretty much you see the same pattern there. meaning as individuals age, we see more and more prescription medications. This is true for the general population, but I think the number of prescription medications is much higher for those with as well as without intellectual disability, as long as they have autism. As you can see, that group after age 35, that's when the acceleration happens in the number of prescription medications. And this shows body mass index. And we have to be concerned about all sorts of health-related conditions that emerge from being overweight. And adolescence is a time of weight gain for all cases. This is a situation where we didn't see a difference between those with intellectual disabilities and those without. More weight gain during younger adult years and then stable after. But when you look at where overweight is on the national norms in the US, which we know we have a difficulty with being overweight in the US, and that's certainly true of people on the autism spectrum. And in the later years, you see that many, many people are obese, and some are very, very high in their BMI. And then lastly, this shows seizures. And for people with intellectual disability, there's a upward trend in terms of the number of individuals who, for the probability of having seizures. And then after age 34, 35, it remains stable. It does not continue statistically upward. And for those without intellectual disability, there's a lower likelihood of having, lower probability of having a seizure disorder, and it does remain at that level in later life. So is age 35 a turning point that would be useful for us to think about? And I guess we think our data suggests possibly. After age 35, autistic adults, both with and without ID, significantly decline in ADLs, increase in prescription medications, both psychotropic and non-psychotropic. And then after age 35, there's chronically elevated BMI and seizures. And for those with ID, chronically elevated impairments and social reciprocity. And we know that from population studies, and I'm just showing two here, that adults with autism spectrum disorder have a shorter than average lifespan by about 20 years. And so it's really, I think we all would agree that attention to health in younger adulthood could potentially reduce this disparity, which is really quite significant and concerning. So that takes me to the second part of my presentation for today, which is looking back. During the period of our study, from the time it began in 1998 through 2019, when we did this analysis and published this paper that's cited on the bottom of the screen, 26 adults in our cohort have died. This is all before COVID, of course. And in order to determine whether someone has died, we obtained multiple confirmatory pieces of information to make sure that, like, if the family, we didn't really doubt whether a family report of death was valid, but for people who there were other sources of information, we obtained two sources of information to confirm that the individual had passed away. So the average age of death of these 26 adults, this is not the average age of death of adults on the autism spectrum, but of these 26 adults, the average age of death was 39, with the youngest person dying at age 18 and the oldest at 65. And then we calculated how much, to what extent are these premature deaths. And the way we did that is for each individual, each of these 26 adults, we used CDC life expectancy tables and calculated their age and sex-specific life expectancy. And then we just subtracted. And the range of years of premature death ranged as high as almost 58 years. And I don't want to say low, because premature death is still significant and concerning at 17 years. But there are many, many individuals in our sample, 6% of the sample in the 20 years that we studied, who really are dying at a young age compared to what would be expected by national norms. These are the causes of death of these 26 individuals: 5 cardiac, 5 cancers, different kinds of cancers, but often detected late due to maybe less access to screening for cancer. 3 people died during seizures, 3 from respiratory failure or pneumonia, 2 medication side effects, and you can see 2 choked on their foods, 1 had accidental poisoning, and 5, we were not able to determine their cause of death. So then we tried to look statistically at what the risk factors were during this 20-year period for mortality. And the risk factors we examined are listed on the screen: biological sex and ID status, but also how old they were at the time the study began, what their health was rated when the study began, their level of ADL self-sufficiency, again, when the study began, and families' retrospective ratings of their social reciprocity impairments at age 4 to 5. And this is what we found. Neither biological sex nor ID status were predictive of mortality in our cohort, again, for these 26 individuals who died versus those who survived. But for every 1 year older in time 1, there was a 7% increase in risk of death during that period. And for health, individuals who were rated in fair or poor health at time 1 had a 46% increased risk of death during the study period. Their ADL skills, their activities of daily living skills, for every 1 point lower on our ADL measure, meaning less self-sufficient, there was a 9% increased risk of death. And the real surprise here, and Kathy and I have talked about this, is that there was a 26% increased risk of death for every 1 point higher on the ADIR during the early childhood period as rated for ages 4 to 5. 26%. And these are all net of each other. In other words, these are net of sex and ID status, but I shouldn't say they're net of each other. These are above and beyond. So let me say a few words about implications and then finish up. I mean, it's well documented that autistic adults often have multiple health problems and more difficulty accessing healthcare. This is all US data. We know there are problems in our healthcare system in general, but we need to advocate for more screening and monitoring of health risk factors for autistic adults. We know that they often have poor ADL skills. Many become less self-sufficient with advancing age, particularly after age 35. But we know that ADL skills are malleable. These could be targets of intervention, and they can lead to maintenance of independence in midlife and old age. So really important. And then social reciprocity is often seen as a particular challenge, but it's also a resource. So individuals whose social reciprocity impairments are lower at age 4 to 5, they may have a lifelong trajectory that is associated with a better quality of life and longer life expectancy, whereas those who have more impairments of social reciprocity in early childhood, they may experience a lifelong trajectory that can affect quality of life and maybe earlier mortality. So my last couple of points has to do with a research agenda. And what I really want to talk about first is research on aging in the general population. And our study was funded by the National Institute of Aging, and I'm a big fan of that agency for selfish reasons. But also, I think what they've done has, in terms of their funding program, can inform what we do in the field of autism. The National Institute on Aging has made major investments in very long longitudinal studies, some of them spanning as long as 30 to 50 years. And there are multiple cohort studies that they have funded and continue to fund. And so the idea of replication across different studies, and as I'll say at the end of the slide, harmonization of data across studies is possible because of this investment that the NIA has made. The next point is another, I think, really important point for us in the autism field. These aging studies have employed research strategies that the methodology can separate individual aging from cohort effects from period effects. And what does that mean? They can take advantage of cohort effects, such as a change in diagnostic procedure or new services or treatments. They can take advantage of period effects by studying what happened to individuals on the autism spectrum, for instance, during the recession that began in 2008, we could do that. And they take advantage of shocks to the system, like what happens during COVID-19 to individuals in their study. And so rather than rejecting earlier research results, which I think in our field, we have a tendency of saying, well, it's different now, and these long longitudinal studies don't necessarily apply to the cohort of today, I think we've got to find a way to take advantage of this and model what happens when new treatments are developed or difficulties in the larger environment occur. The research on aging in the general population is very integrated, very interdisciplinary, taking a biopsychosocial approach, leveraging different types of expertise, and as I said, harmonizing across studies. And I think these points can inform our research agenda as we move forward. And many of these points have been made before, and I won't dwell on them long, but I think the most important needs from my perspective in terms of a research agenda for aging and autism would be interdisciplinary epidemiological longitudinal cohort studies of midlife and older autistic adults, and thinking of how we can make sure that they are representative of the population, and not just those with good access to clinical care. This is a big challenge. And obviously we need to focus on all of the age-related health conditions and mental health diagnoses and service utilization patterns that have been raised throughout this discussion yesterday and today. I'm very interested in studying how having autism affects aging. This is the mechanistic question. There's terrible stress involved with autism for some people, limited access to healthcare more generally, and long-term polypharmacy. And we need to unpack the impact of each of these and other factors that may lead to different patterns of aging. We know so little about how autistic individuals cope with aging-related loss and grief, or how aging in autistic women versus autistic men is manifested. And throughout the process, we need to draw upon multiple voices, autistic adults, family members, researchers, and policymakers, just like is being done in this meeting. So I'll end with gratitude to all the participants in our study who have stayed with us for such a long period of time, to Leanne Smith-DeWalt, who's a great co-investigator leading this effort. Jinko Kong has been our data manager and statistician from the very beginning of our work in autism, and actually before that, when we studied intellectual disability more generally. He has his hands on all the data, which is just enormous contribution. And Renee Mapu, who organizes our data collection. And you see the names of many people on the bottom of the screen, mentioned Jan Greenberg and Marty Krause, who are co-investigators throughout different parts of our study. But the other individuals here, Jason Baker, Summer Bishop, Anna Espenson, Segan Hartley, Matt Maynor, Gail Orsman, Paul Shattuck, and Julie Taylor all made contributions to what you saw today and other indicators of aging. Thank our funding from NIA and NICHD, as well as Autism Speaks and the Wasteland Center. So thank you very much.